Hello, everyone. Welcome to the Zoom meeting. Welcome the new fellows and previous all the batch senior fellows. Welcome. And today, Dr. Maysam will lead the Zoom meeting. I'll give it to you. Go ahead.
Okay. Hello, everyone. I hope you're all doing well. My name is Maysam and I'll be moderating today's meeting, inshallah. We will be having two presentations. The first one will be dizziness in older adults, which will be presented by Dr. Lamya. And the second one is going to be introduction to research questions, and that will be presented by Dr. Maha and myself. And then at the end, if we have any project updates or anything else, we can discuss at the remaining time. So, Dr. Lamya, if you're ready, you can share your screen and start the presentation.
Okay. Assalamu alaikum wa rahmatullah. My name is Lamya. Good afternoon to everyone and Ramadan Mubarak. I am from Yemen and I live in New York, Long Island. Recently, I am Alhamdulillah FMG certified and I'm currently preparing for step 3. I would like to thank you all for your time, and I would like to thank Dr. Nader for giving us this opportunity. My presentation today will be about dizziness in older adults. I will share my screen now. Okay. I'm sorry, I don't know where it did go. So just give me 1 second. Okay, can you see my screen now?
Yes.
Okay. Bismillah ar-Rahman ar-Rahim. My presentation today will be about dizziness in older adults. So today's topic is really interesting and it is really important because it's one of the most common things that we face in primary care clinics. So let's start. Our objective today, we should be able to describe the classification and causes of dizziness in older adults. We should know also the factors that may lead to dizziness in older adults, the elements of evaluation, like history, physical examination, testing, and also the treatment option for dizziness. The topics that we will be covering today is classification and causes of dizziness and evaluation and management of dizziness. So here, what is the importance and complexity of dizziness? Dizziness is a common symptom in older adults. The prevalence in older adults will be between 4% and 30%. Prevalence increases with age, and it is more common in women than in men. What are the challenges that physicians will face? The precise classification is difficult, and we will worry about serious causes, like central nervous system causes. The specific therapy is not available for many, and more than 50% of cases will have multiple causes. Now we will define acute and chronic dizziness, and we will know the difference between them. Acute dizziness is independent of age. It usually results from disorder in one system, and its most common cause include acute vestibular neuritis, cerebrovascular ischemia, and cardiovascular disorder, resulting in hypotension. The chronic dizziness is ongoing for greater than 1 to 2 months, and it's more common in older adults, and it has multifactorial etiology. It is considered a geriatric syndrome and requires multifactorial assessment and intervention strategy. It's also associated with increasing fear or falling and depressive symptoms, fall risk, and general functional disability. Okay. Dizziness classification by symptoms. So we have different symptoms, and every symptoms have different causes. The first symptom is vertigo. It is episodic spinning or rotational sensation. The next one is presyncope. It is sensation of faintness or lightheadedness. Disequilibrium, it's feeling of imbalance on standing or walking. The other is like some of them, they will describe a vague feeling, may be described as floating, lightheadedness, wooziness, or other non-specific sensation. And we have a mixed type, and I want you all to focus on the mixed type because it is the most common type, and it is combination of two or more of the above. So what is the causes of vertigo? We have vestibular disorders, benign paroxysmal positional vertigo, Meniere's disease, idiopathic recurrent vestibulopathy, acoustic neuroma, and cerebrovascular disease. Benign paroxysmal positional vertigo, it is episodic inner ear disorders. It is aggravated or brought on by changes in head position, examine rolling over, gazing up or down. It's sudden onset, stays for seconds, long bouts of vertigo. And it probably results from changes in endolymphatic pressure during head movement, resulting from dislodged otoconia and semicircular canal. The next one will be Meniere's disease. It's idiopathic inner ear disorder, repeated episode of tinnitus, fluctuating hearing loss with sensation of fullness in inner ear, and severe vertigo. We have also presyncope. Presyncope is sensation of faintness or lightheadedness and sign of decreased cerebral perfusion. We have postural, there will be a postural change, dizziness on standing from supine position with or without orthostatic hypotension. We have also postprandial hypotension. So what is postprandial hypotension? This is low blood pressure, which causes fainting because the brain does not receive enough of blood. Why this happens? Because there will be failing of the sensors of the stomach, like the stretch receptors. So they will not sense that eating is coming underway. And it could be caused by a lot of causes, including diabetes and Parkinson and other conditions with nerve damage. The next one is disequilibrium. Disequilibrium is sensation of imbalance or unsteadiness on standing or walking. Many factors can contribute to imbalance, like vision problems, proprioceptive disorders, musculoskeletal disorders, and gait disorders. I just want to make sure, are you with me? Can you hear me?
Yes, loud and clear.
Yes, we're hearing.
Okay, great. Okay, so the other forms of dizziness. Best reserved as description for patients who do not experience vertigo, presyncope, or disequilibrium. So these patients, they will describe their symptoms as floating, lightheaded, wooziness, spaciness, whirling, or other non-specific sensation. The most prominent consideration is psychiatric cause, depression and anxiety. And I want really you to focus with this because you will see it a lot in the clinics. You will see a lot of patients, like they feel dizziness, but you do like examination, physical, you do the lab, you will not find out why, but then you will discover they have like a psychiatric symptom like depression or anxiety. And it's really weird, like that depression caused dizziness. Okay. So the other type is mixed dizziness. It's a combination of 2 or more types of dizziness, as we said before, and is the most common type reported by older adults. Likely result from combination of disease affecting the vestibular, CNS, visual, or proprioceptive system. We have also systemic disorders like anemia, heart failure, diabetes mellitus, and hypothyroidism, which can contribute to instability or dizziness. We also have to consider the carotid sinus hypersensitivity or carotid sinus syndrome in the differential diagnosis. Other really important topic is medication and the relation to dizziness. So in older adults, prescription drug toxicity is important contributor to dizziness. When you are like in a primary care clinic, you will see a lot of older adults. They come with their bag, and the bag has like a lot of medication, antihypertensive, anti-diabetics, vitamins, and a lot of other medications. So you will see with them more than 5, sometimes 5, 6 medication with them. So this causes toxicity sometimes and cause dizziness. This is really important factor. So what are the certain drug that is frequently implicated in dizziness? We have anxiolytics, antihypertensive, antidepressants and antipsychotic, aminoglycosides, non-steroidal anti-inflammatory drug, antihistamines, and anticholinergic. And I want to tell you an example. Like one time I was in the clinic with a doctor, and there was like a lady, she had dizziness. We did everything, and she never told us that she started a new antihypertensive medication, which was like hydrochlorothiazide. And she was complaining of dizziness, and she said, it's unbearable, I'm tired, I don't know why I have dizziness. After medical reconciliation, we discovered that she started like with hydrochlorothiazide. After that, the doctor discontinued the medication and like prescribed other medication. So medication is really important in dizziness. So we have to focus in medication and do medical reconciliation every time we have an older patient with dizziness. Okay, so what is the characteristic of dizziness in older persons? It usually results within days to several months. It's chronic or recurrent symptoms. It has multifactorial etiology, and it's really common, as we said. It's commonly associated with postural hypertension, anxiety, and depression. As we said, the use of 5 or more medication, it impaired gait and balance. And actually, I don't know what is this abbreviation, but maybe it is like, I tried to search about it. It's maybe strength of evidence equals balance. So if anyone have other information, just let me know, because I'm not sure about this. View as a geriatric syndrome requiring multifactorial assessment and intervention strategy. So how we evaluate, we do evaluation of dizziness. We're gonna do a history, of course. So we should elicit the patient on description of the event without prompting. Like we have to learn whether the dizziness is characterized by any of the 3 sensations: spinning, imbalance, or unsteadiness, or fainting. Whether there is a positional effect on the symptoms, frequency and duration of the symptoms. We also gonna ask about symptoms peak at any specific time of the day. So what are the other symptoms are associated with dizziness? Specifically, we will ask about hearing loss, ear fullness, diplopia, dysarthria, and tinnitus. And also we can ask about medication of the patient is taking, including over-the-counter medication. And also how symptoms are affecting the patient quality of life. The other evaluation of dizziness is physical examination. So we're going to take the blood pressure, and pulse while the patient is in supine position, and then after he is standing for 1 to 2 minutes. We're gonna perform provocative test of vestibular system. These are Dix-Hallpike maneuver, the head thrust test, and side lying test. So let me give you a brief explanation about Dix-Hallpike maneuver. We're gonna let the patient to sit with his head tilt 45 degrees, and then we're gonna let him lying and stay for 1 or 2 minutes, and then we're gonna check for nystagmus. The head thrust test is something like we're gonna put the head of the patient and focus let the patient to focus on the examiner nose, and then we're gonna do a sharp turn to the patient head to the right. The normal thing, he will still focus on the nose, but the abnormal thing is he will not focus on the nose, his eyes gonna deviate, and then he will do corrective succeed. Corrective succeed is something like he's trying to put his eyes to the normal position, so this is succeed. And we have also side lying test, and it is something similar to Dix-Hallpike maneuver. We're gonna put also the patient head in 45 degrees in a sitting, then we change, then also for lying, and then we check for nystagmus. Some other important examination we'll do is the cardiac examination. Test hearing and vision and observe for nystagmus. We're going to also observe for the balance and gait of difficulties. And of course, we will do the laboratory testing. In patient with chronic dizziness, we're going to check for hematocrit, glucose, electrolyte, renal function, vitamin B12, folic acid, and thyrotropin. Also, maybe we'll need to do audiometry testing. And this may help if cochlear symptoms are present, like tinnitus, asymmetric hearing loss. It helps to differentiate between acoustic neuroma and Meniere's disease. ECG, if there is cardiac cause suspected, and Holter and event monitor only if there is suspicion of arrhythmia. The Holter monitor is like a device they put in the patient, and I'm not sure how it longs, but maybe 24 hours or more. And it will send information to the doctor and see if there is any arrhythmias. We have also the tilt table test. It's only in select patients with postural hypotension or syncope. The tilt table test, they put the patient in a table and they secure him, and then they tilt the table for maybe 70 degrees. And then they will monitor the vitals for 10 to 60 minutes. Okay, and we're gonna do of course, vestibular testing, electronystagmography, unilateral dysfunction, rotational chair test, bilateral dysfunction. We're gonna also do the CT and MRI is occasionally warranted. Now we come to the most important topic, which is how to manage dizziness. We'll start by the first symptom, which is vertigo. So how can we treat benign paroxysmal positional vertigo? We're going to do Epley maneuver is the treatment of choice, and I will explain it later. In Meniere disease, we're going to do salt restriction, diuretic, vestibular suppressant, maybe helpful during acute attack. In severe cases, may need surgery, including endolymphatic decompression, vestibular nerve resection, and labyrinthectomy. In ototoxic medication, aminoglycoside, diuretic, non-steroidal anti-inflammatory drug, we're going to discontinue or substitute or reduce the dose of the offending medication, as I told you before with the example of hydrochlorothiazide with the patient. Okay, then we have the treatment of pre-syncope. The causes like cerebral ischemia, secondary to orthostatic hypotension, cardiac cause, dehydration, medication, vasovagal attack, autonomic dysfunction, secondary to diabetes or Parkinsonism. The treatment going to be treatment of specific cause like proper hydration or dosage adjustment or removal of the offending medication, or slow rising from sitting or lying down position, graduated support stocking, Also the prescribed treatment and over-the-counter treatment medication, we're going to give them like fludrocortisone and midodurine as needed. The postprandial hypertension, how we solve this issue, we let the patient know to have frequent small meals and avoid exertion after meals, slow rising from sitting position, avoid antihypertensive drug at or near mealtime. So how we manage this equilibrium? The vertebral-basilar ischemia and or cerebral infarct or hemorrhage, we're going to give them low-dose aspirin, clopidogrel, and extended-release dibridamol aspirin rehabilitation. Cerebropontine angle tumor, acoustic neuroma, obviously it will be surgery. Parkinson's disease, we're going to do drug therapy and rehabilitation therapy. Peripheral neuropathy, secondary to diabetes, vitamin B12 deficiency, idiopathic, we're going to treat the underlying disease. Okay, cervical spine degenerative arthritis and spondylosis, cervical or vestibular rehabilitation, and cervical collar surgery if needed. And the other causes, how we manage the other causes, like for example, as I told you before, anxiety and depression is an important factor. Or psychosomatic disorder. So how can we treat this? With psychotherapy and antidepressant therapy. So the management of mixed type of dizziness, like medication, like anti-anxiety drug, antidepressant, anticonvulsant, antipsychotic, antihypertensive, anticholinergic, we're going to discontinue or reduce the dose or substitute the medication. The combination of any of the above causes will be multifactorial intervention. Okay, this is Ebley maneuver. Ebley maneuver is a series of head movements that relieve the symptoms of benign positional vertigo. It helps to relocate the calcium carbonate crystals. It helps to relocate them from the article back to the semicircular canal, where it belongs. So how we will do this maneuver? We will turn the patient 45 degrees toward the affected side. He will, in the beginning, he will be sitting and we turn him 45 degrees toward the affected side. Then the next step, we're gonna keep the patient head turned and lie him down. Then we will turn the head 90 degrees to the unaffected side. After that, we will turn the head another 90 degrees to the unaffected side also. And then we will turn the head then we will sit the patient up while keeping the patient head turned and flexed. So this will help him to dislodge as we said, the calcium carbonate or the particles in his ear to the semicircular canal. The summary here is a precise classification of dizziness into vertigo, presyncope, disequilibrium, and lightheadedness is often difficult, and multiple causes of the same symptoms are common. Most dizziness resolve within days to several months. It is important to elicit a detailed history from the patient, including medication history. The key physical exam steps include checking for orthostatic hypotension, performing the head hanging Dix-Hallberg test, as we explained before, and observing the gait. Treatment of dizziness focuses on treating the underlying cause or disorder. So we will have 3 cases, and I will check now your understanding. I hope everyone focused good with me. I will help you, okay? So we have a 72-year-old man comes to the emergency department because he had sudden onset of vertigo, nausea, blurry vision, and left facial numbness while watching TV. Left facial numbness. The symptoms lasted for a few minutes before resolving completely. He had 2 similar episodes over the previous 3 days. History, he have hypertension, hyperlipidemia, 50-year history of cigarette smoking. The examination, the blood pressure was 153/90, high blood pressure, heart rate is 78 per minute, and regular respiratory rate 14 per minute. Oxygen saturation was 98, on room air, neurologic, and all other findings are normal. CT of the head is normal. So the question is, which one of the following would most likely establish the diagnosis for this patient? Is it the Dix Hallweg test, CT angiography of the head and neck, Doppler ultrasonography of the carotid arteries, magnetic resonance imaging, MRI of the brain? I will give you a few seconds to think and just send me your answer in the chat. C, Isra, Lana, C. Okay. Okay. We'll see. The answer is B. Most of you, they said C. I know why you're thinking about C. But CT angiography of the head and neck. We will do, because here he said we have numbness while watching TV. Okay, so we're gonna think about something with you think also about the carotid arteries, but we're gonna see CT angio of the head and neck that's give us more information. Okay. The next case is a 75-year-old man is brought to the emergency department because he had an episode in which he lost consciousness. He recalls standing 45 minutes after dinner and suddenly feeling dizzy. So 45 minutes after dinner, okay? Or lightheaded with a generalized weakness. He next remembered being on the floor, incontinent of urine, 3 minutes, had passed it since he had last checked the clock. He immediately lied down and called 911. When the ambulance arrived, blood pressure was 90/60, low blood pressure, focus here, okay? He does not recall any focal neurologic symptoms. History, hyperlipidemia, gout myocardial infarction 10 years ago, okay? So the question here is, which one of the following is the most likely diagnosis? Is it vasovagal syncope, generalized tonic-clonic seizure, postprandial hypotension, and basilar transient ischemic attack? Okay, let me see your answers. CCA, AAC, okay, C. Good. Most of you, they answered C, and it is postprandial hypotension, okay? Because he described his dizziness after standing 45 minutes after dinner. And also he had low blood pressure. And as we explained in postprandial dizziness, there will be low blood pressure because all the blood stays in the stomach and not going to the brain. Like us now with Ramadan, we eating after we eat, we feel all like tired, dizzy. So this is why. The last question is, which of the following, sorry, this is the same question. The last question is, an 83-year-old woman comes to the office because she has had episode of dizziness in the past month. Her husband died 1 year ago. Sadly, her husband died 1 year ago. She has a continual unsteadiness that is unchanged by position. There is no new numbness or weakness. She has not fallen, but the unsteadiness has caused her to turn down invitations and stop going to her weekly bridge game. She has not been sleeping well. She has a history of hypertension, osteoarthritis, and glaucoma. With examination, she appears thin, but in no distress. She has lost 2.3 pounds, 5 pounds, 2.3 kilos since her last visit. Normal orthostatic vital signs, grossly intact visual acuity and hearing. She has a full strength. Sensory examination is normal to pinprick and vibratory sensation in all extremities. 2+ reflexes throughout. Gait is slow and hesitant, but narrow-based and steady. So the question is, Which one of the following is the best next step? Obtain magnetic resonance imaging, MRI of the cervical spine, perform Dix-Hallback test, screen for depression, and conduct tilt table test. I want to see the answers. C. Okay, depression. Good job. Okay. Right, it is depression. As we say, like depression is hidden symptoms that we have to ask and to screen for depression in adults because it causes dizziness. Okay, and that was the last slide. Thank you. Thank you all.
Thank you so much, Dr. Lamya. This is excellent presentation.
Thank you.
It's a big topic and important one, as you mentioned.
Okay, thank you, Lamya, for this thorough presentation. If you guys have no questions, we can move on to the next presentation. Dr. Maha, you can start.
So thank you, Dr. Lamya, for the excellent presentation. So hello, everyone. I'm going to share.
Can I ask a question?
Yes, go ahead.
Go ahead.
Yes, regarding the first question, there's a first case in the previous presentation.
Okay.
I'm just confused. We didn't choose the carotid ultrasound because it is vertebro-basilar, right?
Yes.
Okay, I was making sure that that is the reason why we choose the CT angiography.
Okay. Thank you.
Okay, thank you.
So, can everyone see my
Yes,
screen now?
Yeah.
Okay, hello,
Yes.
everyone. My name is, thank you. Hello, everyone. My name is Dr. Maha Mohammed. I'll be presenting today how to formulate a research question with Dr. Maysam. So let me start with this quote by Richard J. Light from his book By Design. He wrote, well-crafted questions guide the systematic planning of research. Formulating your questions precisely enables you to design a study with a good chance of answering them. So by the end of this presentation, we will be able to know the importance of a research question, the criteria of a good research question, how to formulate a research question, and how to refine a research question. So why is a research question important? Well, it focuses and directs research to the desired area of inquiry. It creates a research design, like your methodology, your data collection methods, your analysis techniques. It assesses the scope of the study, like population and sample size. It sets expectations of what the study will achieve. It provides new knowledge and existing research. So what are the criteria of a good research question? So first, a research question should be feasible. That it should be within the ability of the investigator in terms of methodology, time, and funds. Interesting for the researcher to be motivated to carry on. Novel, it shouldn't be a copy of other research questions investigated by other researchers. Ethical, like we all know, it should minimize the risk of harm to the participants, maintain their confidentiality, and give them the right to withdraw from the study at any time they want. Relevant in terms of intellectual interest to people in the field, like filling a gap in knowledge manageable to follow by the researcher, appropriate logically and scientifically for the community and the institution. It should be of potential value and publishability, that it could make a significant health impact on clinical and community practices and could resolve important health dilemmas. Systematic, it should have a specific structure, but at the same time doesn't rule out creative thinking. So how to formulate a research question? You should start by identifying a topic of interest. It could be very broad at the beginning, like for example, risk factors of hypertension. Then review literature and gather information. In this step, you should ask yourself two important questions. What do you already know about the topic? What do you still need to know? Because the next step is building your research question, and it depends on how you answer those two questions. After that comes the refining, where you narrow down the research question. For example, take the previous example of risk factors for hypertension and try to narrow it down by age group, ethnicity, kidney disorders, heart disorders, and that's it. And choose a topic of your interest, and then develop hypothesis, and ask yourself again what argument is going to be made, because hypotheses consist of more specific prediction about the nature and direction of the relationship between the variables. And last but not least, share the results with colleagues and mentors for feedback. So thank you, everyone. Now my colleague, Dr. Maysam, will carry on.
Okay, thank you, Dr. Maha. So next we have how to define the research question. So one of the ways you can do this is to formulate and define the research question by using a structured format. And one of the most commonly used formats is what we call the PICO or PICOTS format. So this is an abbreviation that stands for population, intervention, comparator, outcome, timing, and setting. So first of all, you need to focus on the population. So you can identify your population by selecting the disease or the condition of interest. And you can also specify whether your research paper will focus even on a specific subpopulation of individuals. So are you going to focus on a specific age group, any disease severity, any existence of comorbidities, and things like that. Next, we have the intervention and comparator. These usually come hand in hand. You will most likely compare at least two alternative interventions, treatments, or systems of care. So, for example, you can consider a certain intervention versus no intervention at all. This is, as I mentioned, where it comes the intervention and the comparator. Next, we have the outcome. So it's important to remember that you should seek to address all the outcomes that are important to patients and clinicians. So just don't only focus on things that clinicians usually focus on. Keep the patient in mind so that in the outcome of your research. So you can focus on, let's say, benefits of certain interventions, possible adverse effects of a certain intervention, quality of life, and maybe even patient satisfaction and things like that. So some people also include in this PICO format the T and the S, and these refer to the timing and the setting. So you can focus on timing of the outcome assessment and the setting. So this sort of helps set the context of your research. And setting could also include, are you going to do your research on primary or specialty care patients, inpatients or outpatients? Are there going to be any co-interventions and things like that? So if we take an example, if you can go to the next page, next slide. Okay. So this is an example here. If we take an example of how you can actually practically apply the PICO format, if you guys look with me at the table here, we have the first column, the PICO components, and then second column shows tips for building your question. So let's say you want to choose your patient population or the problem. You can ask yourself, how would I describe this group of patients? So keep in mind that you need to balance precision and brevity. So you need to be precise, but also accurate as well. So let's say you can say in patients with heart failure from dilated cardiomyopathy who are intimestable. So this is a very specific group of patients which you have described. Next comes the intervention. So this could be a cause, a prognostic factor, or treatment. You can ask yourself which main intervention is of interest. Again, you need to be very specific. So you can say, would adding anticoagulation with warfarin to standard heart failure therapy, and then moving on to comparison intervention, if necessary, of course. What is the main alternative to be compared with the intervention? This is what you ask yourself to figure out the comparison group. So you can say here in this example, when compared with standard therapy alone. So here we're comparing anticoagulation with warfarin to the standard therapy heart failure versus only the standard therapy alone. And then we have the outcome. So you can ask yourself, what do I hope the intervention will accomplish? And what could this exposure really affect? Again, you need to be very specific. So you can say, will this lead to lower mortality or morbidity from thromboembolism? And is this enough to be worth the increased risk of bleeding? So keep in mind here that you can even have more than one outcome. You can have a primary outcome and other secondary outcomes as well. Okay. So finally, we have our conclusion. So it's very important to keep in mind that topic formulation is a challenging process that requires a lot of time, maybe even greater than you have initially anticipated. The research question should satisfy the criteria which Dr. Maha has already mentioned. It needs to be feasible, interesting, novel, ethical. Patients can come out whenever they want. It has to be relevant, manageable, appropriate, potential value, and publishable, and systematic. You can also keep in mind that you can focus on the uncertainties in practice. Again, this fits with the idea that it has to be novel, so that your paper is not just a repetition. Keep in mind the outcomes and interventions that matter to the patient, as I mentioned, not only the clinicians. You can follow the PICO format, and this will really help you narrow and refine your question as you go along. Give it time, go back to the literature, modify, and refine as you go. Thank you all, and if you have any questions, go ahead.
Thank you both for a great presentation. Excellent. Thanks. Do we have any questions for the presenters?
I think Nada has a question.
I have a question. I just wanted to ask regarding the PICO, how would it be kind of used in systemic review, for example, since there wouldn't be an intervention? It would be kind of a comparison between different researches. Would it be the same? Would we use PICO as well?
Okay, I'm going to answer, and of course, if there's any mistake, Dr. Nader can correct us. I think, yeah, it's probably going to be the same thing. It's just like the intervention is going to be different papers. So you can focus on a certain paper that uses a certain intervention, and then you can collect other papers which use a different intervention. It's just the difference is you won't be actually doing the intervention. It's just comparing different papers that provide different interventions.
Okay, thank you so much.
You're welcome.
Thank you for the question and the answer. Any other questions? So I'm gonna just apply the last concepts that we discussed about the research question. So there is long-term and subacute medicine. It's like the area where I'm specialized, and they have a journal. So I'm gonna share the screen with you guys, and this is their. So this is a website basically for the journal. It's last year, the issue is the year. So they sent some papers or some abstract, and they were accepted and presented in the conference. So some of them are here. So, for example, here are the topic about future of nursing home post-acute medicine or care. So the topic could be just in general, the research question, what we are doing in the future, so we can look at the past and look at the future. These are letters to the journal, but they talk about special articles like the services they provide, the financing, payment, imperative. All these are examples of questions, and they want to answer. You don't have to follow certain criteria. If you want to say, I want to just look at the quality improvement, so you will work on that as well. So there are different ways of doing the research, if that makes sense. So what we need to focus on here in the fellowship is to focus on the steps. So let's say you come up with an idea and you want to work on this project or this idea. So you read about it. Number one, you want to see if there is any publication, anything in the literature about the idea that you are trying to research or do some work on. So you get familiar with what you are trying to study. Number two, try to find a gap where you want to study to get the information into that literature. What's missing there? Number three, try to minimize or shorten your question. So let's say you want to study telemedicine use in older adults in general. So how they use it to see the patient and the physician and back and forth. This is a big question. You want to make it shorter or you want to make it focused, and you can limit it to the title will be, I want to study the telemedicine use in older adults during COVID. So it's just a certain period of time. It's not like since telemedicine started in the 70s. If you want to limit it again, you can use it with telemedicine use in older adults during COVID using smartphones. So you only want to see how people are using smartphones, not computers, not tablets, not other devices. So you want to focus on a very limited area so that people will come and be interested in your topic, and it's going to be doable for you. So if you want to do it, we can talk about the methodology next week. But the idea is you want to limit it so that you can carry on with your project. You can finish it, you can publish it, and be of interest to whatever group you want to present to. In this case, for example, the people in long term. If you are doing internal medicine, you can go to the American Medical Association, present to the internal medicine group, or if you are interested in other subspecialties like cardiology, you can focus on certain area and then present that to the cardiology group, either in a conference, or maybe you can write it as a manuscript and submit it to the journal in cardiology, if that makes sense for you guys. Any questions? Do we have ideas? Go ahead, Neda.
I just had a question regarding the fellows who aren't currently affiliated with a hospital. How are they going to collect the sample size, for example, or because we'll have to put this in mind when we're choosing the research question? Like, would we be able to collect it? Would it be a teamwork? Another member who is affiliated with a hospital maybe would be able to collect it? How are we going to approach it?
Excellent question, thanks. So if you are looking at the clinical part, yes, you need to look at the chart and so forth. So you need someone who's within that hospital system. So it depends on where you want to do your research. Let's say you want to study the pacemaker in older adults in patients with, let's say, chronic kidney disease. You want to limit yourself into, let's say, in Michigan. And then you can see what hospitals you want to see and you want to review your chart. Here in Michigan, in Lansing, where I live, we have two big hospitals. One of them is Sparrow. So in the past, we did some research work with them. So I'm affiliated with them, so I can access the charts. And there is another physician in the group also can access the charts. So we can get the information from the hospital records. So that one way. If you want to do it in a different, let's say in Flint, in a different city in Michigan, there might be another physician in the Henry Ford or other system there. If we can collaborate with them, they can look at the chart and then get the information. So it needs to be used or accessed by someone who's in the system at the hospital or the healthcare system, so they can access the information from the patient's chart. Sometimes the question might be a general question, so you don't have to look at individual patient chart. You may look at the total. But what I'm saying is there are some databases where they collect all the information from the hospitals and put it in one place. It's called the National Inpatient Database. So we can access this database, so you don't have to worry about individual patients. And you're going to go with the same concept of the question. You want to say, I want to look at the use of, let's say, the portal system by all the adults during their hospitalization or after their hospitalization. If this data is collected and saved in the National Inpatient Database, then it's just a matter of sending the question and you're going to collect the information, or you're going to collect all the data from the National Inpatient Database, and then you're going to review your question with the data, collect all the information from the data. You don't have to find someone in a specific hospital or a specific healthcare system, if that makes sense.
Yes, it does. Thank you so much.
You're welcome. Good question. Any other question? Go ahead, Sahar.
Yes, hi, Dr. Nader, and hi, everyone. So you said, like, after I decide my question, I should check the literature of if anyone did like some research in that about that topic. So which or what are the best sites that I can look for literature in there? Can you hear me, Dr. Nader?
The last part of the question, which
sites I can look for the literature about the topic that I'm looking, like to check about the topic if anyone have already researched about it.
Yeah, so there is the website PubMed.
Okay.
Most of the people use it. There are other databases there as well, but you can search with that. You can start with that, and depending on and see if you find anyone wrote about it.
Okay, thank you.
You're welcome. Good question. Any other questions?
Assalamu alaikum, Dr.
Safa,
Nader.
go ahead.
Yeah, you can hear me?
Yes, go ahead.
Okay, I will present the third and fourth part of the presentation today. Let me share my screen.
Thank you.
You can see my screen now?
Yes.
Great. Okay. Okay, now we're going to talk about the use of whiteboard in Zoom presentation. If you are presenting, you're going to like the incredible features of whiteboard. So let's go. First, you're going to start to open new meeting and get the meeting ID and password. After that, you're going to share it with your meeting partners and use the whiteboard button in the screen. Let's see. Here, the Zoom website. You're going to press in the new meeting if you can find here. After that, this screen will pop up. You can see the green button over here. If you press on it, you're going to have the passcode and meeting ID, or you can share it with the link. And also here, if you can see down, take this away. Okay, you can find the whiteboard over here. If you press on it, it will take you to this screen. No, it's not moving. Yeah, it will take you to this screen. In this screen, you can see that you can print, you can write text, you can add any figures, and also you can erase. And also, if you go to this place, you can have more settings. You can allow or disallow any member in your meeting to write in your screen. Also, here you have many pages. For more information, I will show you short video to understand more. Okay, let's see. Doesn't move. Sorry for these technical issues. Maybe I need to find this one. Okay, now. I'm sorry, but it looks like there is some technical issues. I cannot open the YouTube now.
That's fine. You can just do the demo and people can follow.
Okay, so now we talk about the whiteboard over here. So you can print, you can add text, you can also let the friends to write in your screen, and so you can collaborate with them. And also you can break through the screen. So you can make a question for every one of them, and everyone can write in that screen separately. So that's the new feature you can use in the whiteboard. Also, you can have many pages, not just one page. so you can go and come back. For the video, you can watch it in the app. You can find it over there. So this is the end of the third part. The fourth part is about the research topic finding. Okay, when you are looking for research topic, you have to put in mind three main points. The first is the interesting. If you are interested in the project that you do, you can continue on it because you're going to take long time. If you are not interested in that, you're going to lose your motivation and you cannot go ahead on it. The second part is the novelty. What's the point to making any project if you are not creating new things? So be creative and choose something no one do. After that, to be manageable. Sometimes you underestimate the duties that you have to do in specific times, and most of us are studying and we don't have time. So you have to be easy on yourself and try something you can do, and also be aware of the thing that you're going to do, like questionnaire, or we are going for imaging or lab. So try to do something you can do. In approaching the research topic, you have to do some things for approaching it. The first is to find a professor that he can share with you the project. The professor may have his own group team, so he may also help you or assist you to find any another professor can help you to find your research. The second thing is to track other researchers and try to know what's the last research and what's the fundamentals you have to look for in your research. The third thing is run an internet research, ask the instructor to help you where you can find, and also you can ask your colleagues and classmates if you can find good or hot field to look for. Okay, how to find research topic. When you read an abstracts, you can find it with the using of the keywords. If you can find the keywords what you are looking for, you can find other abstracts that can have the same object you are looking for. This is some websites, as Dr. Sahar was asking about. This website you can look on and can give you good information. I would like to share with you some videos, but I don't know if my computer will let me. I'm sorry, it looks like I have technical issue. That's why it looks like we cannot see the video. So that's the end of the part 4. Thank you for listening and good luck, everyone.
Thank you so much for the great presentation, Dr. Safa. And any questions? So this is one of the tools that we can use, and I'm gonna just demonstrate how we can use it in this program. For instance, some of you might, I'm gonna ask you to stop the screen sharing, Dr. Safa, so I'm gonna share mine. So here we go. So if we have the whiteboard in Zoom, how can we set it up? So basically, you can share your screen, and when you share your screen, you're gonna unshare and show you what I mean. When you hit share the screen, it's gonna bring a screen like this.
Doctor, I'm sorry, we cannot see the screen.
I'm gonna share it with you just a second. So now you can look at this. So you can have the option of capturing all your screen, or you can have specific programs that are open, or you can use the whiteboard. So when you click on the whiteboard here, you can see my screen, right? Or
Yes, we can see.
Yes.
so this is where you hit the white screen or whiteboard. So when you do that, I'm gonna do it again, but this time it's gonna be active. So you have the ability to use the pen to write or draw, or you can have the text, let's say one. So if I'm talking about this fellowship, so we will talk about the teamwork. So I'm gonna divide you guys into groups. So group 1 and group 2, for example. So I can just circle here, this group 1, this group 2. So I can then talk about, I'm gonna divide group 1 into 2 separate groups. Let's say A and then B. So I have group 1, I can divide into A and B, or in our program, we can talk about the team. So we have the white team, the blue team. So if I ask the team leader for, let's say the blue team, to divide the group into, or team players or team members into 2 subgroup, let's call them A and B. So A will take care of, let's say, give them some task, and then B will do a different task. So by that, I'm simplifying things for the viewers, or in this case, the fellows currently joining us here in this presentation. So everyone will be on the same page. So if I say, now we are talking about blue team, so no one will have any confusion. So when I'm talking about the blue team, we're going to divide the blue team into A and B. A will present next week about whatever topics, and then B will do whatever demonstration. So each member in group A will try to complete the task and be ready for next meeting, and every member in the other group will be also ready to present. If this is, if that makes sense for you guys to use this whiteboard for teaching. So when you have a concept, or when you have a discussion you want to share, or you want to explain things, ideas, you can use the whiteboard so that the other people in the Zoom meeting will follow you closely, and everything will be clear. It's very helpful in teaching, but we can use it in other meetings, talking about projects, for example. I want to do this project, so the team will get into the same whiteboard, and everyone can chip in. And as Dr. Safa mentioned, this can be shared. So some other member from the fellows can join in, and they can use the same mouse from their computer and then add, edit, or make changes. Any questions? Dr. Osama, go ahead. Osama Osman.
Yes. Hello, everyone. Hi, Dr. Nadir. Thank you so much. My question is about the novelty in when choosing the topic, the research topic. So, sometime when you choose like topic with is not too much done in the literature, you will come up with less topics in the literature to gather information from. And the most you add filter to your search criteria, the less topic you get at the end. So at this time, does that mean it is invalid topic? I need to change to choose another topic, or there is a solution for this issue?
Excellent question. And I think it has two parts to it. So the first part is literature, where you want to know what's going on about your idea. So I'm going to demonstrate that with this screen. So these people here talked about telehealth, palliative care in nursing homes, a scoping review. So if I'm thinking about, I want to talk or do my research about telemedicine or telehealth with a palliative care. So people already did some review, so I can look at that, and they have done some part in this paper. They found 11 articles. So if I did the same method of searching with what they were doing, using keywords, as you mentioned, it will limit very few numbers for the result for me. So this is the first part. So if you are looking for the question, you want to get the literature, you want to know what's going on, you may have very limited result if your question is limited, if that makes sense. The first part. So you are just looking at the literature. And when you look at the literature, you want to focus, it's going to be very limited. So the solution for that is you look at the literature without focusing very tight on the topic. So in that case, I want you to look at the telehealth in general. So read about it and get information for yourself about what's going on with telehealth, like the devices used and the technology, the internet, just in general. Then you're gonna talk about, or you're gonna search, and you're gonna self-taught, tell yourself about the palliative care. If you don't know it, you study it, and then you combine both of them. You have some knowledge now. And if you do the literature, it's going to be just for the knowledge acquisition for yourself. So when you want to do the research yourself, here will be part 2. So you gain the knowledge about the basics of telehealth, the basics of palliative care. So you're kind of expert in this area, but we want to study the gap. So when you want to study the gap, you want to go in the literature and find what's missing. What can we figure out things that are not done in the past? In this case, this group, they looked at the group or the patients population in a nursing home, or the setting is nursing homes. And they want to look at what papers are published in this specific group of patients. And they ended up using the Prisma, and the results were 11 papers or articles that are published. So this was ended in January of last year. So this is how they did it. See what's the difference? The first part is you want to know about the idea that you want to address. So you want to gain knowledge about the telehealth. If you know everything about telehealth, you know about the palliative care. If you use only these two as a keyword, you're gonna get a lot of publications, thousands. So you want to just look at in all the others, you limit that so that you can manage the articles that you want to read and study and know about them. If you only want to focus on the knowledge part, searching for the knowledge part. When you are satisfied with the area of the knowledge and you can figure out there is some areas where there is a gap in knowledge, or there is area where you can do some studies or some more. And to do that, for example, I'm gonna suggest a topic for you guys if you are interested in doing a topic similar one to this. So telehealth, palliative care, nursing homes. And this is a review, but that was ended in January of last year. So why don't we look at what happened after January? So we're gonna study the same, we're gonna do the same method. We're gonna search these engines and see if after January 2022, if there are more papers published. Let's say there are 8 or 10 more papers. So we can do the same research they did, but they were limited because they limit themselves to January of 2022. But now we are in 2023, so we have more than 1 year gap, and people can publish in this gap or this area. So if you are interested, you can do the same topic, the same method, but the difference will be only on the duration. So they started 1 year, 2021 to 2022. So what we can do is we can say we studied the same topic, but from January 2022 to now is April 2023, and see if we find let's say 8 or 10 articles, then we will review these articles for the method, and then we will do the same. We will come up with some conclusions. Maybe it's different. Maybe we can augment or support their conclusion, and the implication if there is anything that's found new here. And the topic, we can change it, is we can put it into perspective, like what happened during COVID. So instead of using telehealth palliative care, can we make it towards during COVID? So we can capture the area where they focus on 2021 to 2022. We are focusing 2022 to 2023, and we can finish the project in no time because it's a review, systemic review. So this is how you think about the topic, how you search the web or the engines to get the knowledge and then find the gap. And then the second part is how you can do the literature review if you want to do a systematic review to fill in that gap. So for instance, this gap is the timing. So they know something about telehealth and palliative care, but the limitation is until last year. Many things change in 1 year. So let's say technology change or whatever. So we can come up with some maybe different conclusion, or maybe we can come up with the same conclusion. You never know until you find the studies that are published, or as you mentioned, maybe there are there are limited articles published. Then at least you will say, oh, we did it, and it appears no more articles, and that we agree with this group that this area needs to be more studied in the future, if that makes sense. Go ahead, Dr. Safa.
Thank you so much, Dr. Nader.
Thank you, Doctor. I just want to ask you a question. If we are looking for specific statistics for any diseases in specific area, where we can look, where we can find the record, did we have to go to the hospitals, or there is a specific place we can go to? Excuse me, doctor, I cannot hear you. I don't know if the others can hear
Sorry,
you.
I was muted. Yeah, I was muted. Sorry for that. So it's a good question. Thank you. And to answer this can be done different ways. So here in the US, most, if not all, the hospital system now are electronic. In other countries, I think most of them are going that way as well. Maybe in some part of the world, you will find some still paperwork charts. In any case, you want to look at a specific disease, let's say multiple sclerosis, in patients with whatever you want to specify things. So your disease, you have it, then you can go into the patient chart and see every chart, see which patient has it, which patient doesn't have it, if that's a question. In the past, that was done manually. So you either open the paper chart, or in recent years, you open the electronic record for each patient. But with technology, now it's easier. Here, at least in the US, they use a coding system where it's ICD-10. So for that diagnosis or that disease, there is a code with a letter and number. So for example, COPD, the J44.9. This is the code for COPD. Or if there is COPD exacerbation, then it's going to be J44.1, indicating that's an exacerbation of the disease. So with using one of these or two, then you ask the IT, the technology people in the system, the hospital, tell them, I want to look at all patients who were admitted, who they have this code in their chart. So they will just run a query, and it's going to be within 1 minute, you will have all the charts that indicate that the patient in this group have this the disease. Then you can look at this chart if you want to see additional information from these patients.
So how can I get? So how can I get the code for that disease?
The code is it's simple. So you go to just stop sharing. So if you Google it, like COPD, ICD-10, any condition, multiple sclerosis, for example. Multiple sclerosis, ICD-10, it will show you the G35. So just Google it or search it with ICD-10.
Yeah, that's very helpful. Thank you so much.
You're welcome. Good question. Any other questions? Mina? Any?
Yes, doctor, I didn't understand the part of ICD-10. Sorry. So we want to search for the code for a disease.
So let me back up. So in the past, we have the chart, the paper chart. So when you write your note, we teach you write the assessment and plan. In your assessment, you will say that the patient come with COPD exacerbation. They have hypertension, they have diabetes. So all these three can be written in the chart. Sometimes patient and the physician might write it hypertension, HTN, instead of the whole thing. So abbreviation, right? So when we use a computer to look for patients with hypertension, we have to figure out which physician wrote it what the way. So some people use the abbreviation HTN. Some people put it hyperten and they forget about ION. Some people put it the whole thing. So the computer will get confused. So it's going to take a lot of time for us to figure out how many ways just for hypertension people are using or writing it. The easier way, because it's computerized nowadays, to use a coding system where we put numbers of letters and indicating the condition, no matter how they write it, if you write it in person or in.
Okay.
Does it make sense? So in my note, for example, when I see a patient, I'll put it HTN, hypertension. My colleague, he has some time, so he spell it out, the whole letters, hypertension, the 15 letters. Does it make sense? So
Yes, but when we search,
when I want to look back for last year, how many patients with hypertension did I see? I'm not going to go one by one, right? And
yes.
if I'm in a group with my colleague, and I'm not going to look for my way of writing hypertension versus his way of writing hypertension. We can figure it out, but it's going to take a long time to write a query or a script for a computer to figure out, to search for the chart. The easier way, when I put my diagnosis, HTN, I put beside it I-10,
ICD-10.
ICD-10. So I put it hypertension like that. I put so it's gonna come with hypertension. Where is it? So it's gonna be I-10. I-10 stands for hypertension, just the primary hypertension or essential hypertension. Okay. So if I put it only HTN and my friend put it hypertension and another one put it essential hypertension and the fourth one put it primary hypertension. So the condition is the same, but when we write in the computer, when we write in the notes, each one of us is writing it differently.
Okay.
So for two reasons. For reason number one, for the insurance, when they want to pay the doctor, they want to use certain criteria. One of them is how many conditions the patient has. So they will look at this code existing. So they will look at I-10, for example, this number here, and say, oh yeah, this patient has hypertension. So using only the ICD-10 for them is easier than going for the chart using HTN, hypertension, essential hypertension, primary hypertension for the insurance purposes. So this is one way. When they look at the chart, they want to look at them with only the codes. They don't care about how physician write the diagnosis, if that makes sense.
So whenever we write the diagnosis, we write, I mean, for example, if I'm gonna write the diagnosis for a patient, essential hypertension, and I will write it completely, and then I should write the code for this, for the hypertension I-10, so that whenever someone search for the diagnosis, it comes up.
Yes.
Okay.
Yes.
Thank you. And
so,
each diagnosis has its own code, right?
Correct. Yes.
Okay. Thank you, doctor. Sorry for that.
You're welcome. No. And this will help also for the search part when we're doing the research part. If we want to review the chart, this is a faster way of looking at, let's say I want to see all the patients with hypertension who were admitted to this hospital in the period 2023 in January and February, for example. So I'm gonna just ask the IT people, I tell them, hey, can you just look at all the patients with this code? And within seconds, they can run the query and give me a total number of patients and their IDs, and I can go back and look at the chart for all these patients if I want to look at specific things inside the chart.
Okay, thank you, doctor.
Yeah, we use that with first batch. We were lucky to work with a group, and they have a topic about COVID and chronic conditions. So they actually they presented that in different conferences. We can share with you the screen. So this is the list of presentation or posters presented in some of the conferences in the past 2 years, 3 years. We presented different things. So one of them is this topic. So the idea for the research at that time, one of the fellows say, let's talk about the chronic condition in patients who were admitted to the hospital and they have COVID. So what we did is we asked the IT team and the hospital, we gave them only the code for chronic conditions, let's say coronary artery disease, diabetes, so 4 or 5 conditions, and the condition that we are interested in, COVID. So they have the code for COVID. So we gave them the list of these codes, and within 1 day they gave us all the information that we need to look at. So for us, it was easier to get information from the charts using the technology, just using these codes.
Assalamu alaikum, Dr. Nader. So we have a
Alaikum
question. So is it
Yes.
the regarding the code, is it like just universal or is specific
Yes.
for each of the? Oh, all right.
It's an international, and this is the 10th version. In past few years, it was the 9th version, but they updated, and I think other places using it. So I'm not sure about Europe or other area, but here in the US at least, we are using it. Go ahead, Dana.
Thank you.
Yeah, thank you, Dr. Nader, for these informations. But I was wondering if we are now not working or we just doing, observership at any hospital. Many hospitals refuse to give us information because of HIPAA. So, and if we have or we come up with a new idea or new research question, what options do we have? What should we do to make this research happen?
This is excellent question. Thank you for asking. So this is where the collaboration comes. So if you are working in a hospital where there is residency, then you can talk to the residency people there. The residents may be interested in the same topic, so they have access, but they don't have time to do the whole research. So if you have the idea, they have the access, you can work together. So they will give you the access to the data. You will give them your time and you will work together to create the project and then collect the data and analyze and then present. And it's going to be profitable, or the benefit will be for you and for them. So they are required to do some research. Some of them, they do it because they want to go to the subspecialties. So if they have time, they can do that alone. But they will be open for collaboration. So if you find some physicians or some residents who are interested in the same topic, or maybe they want to work with you, you can just start working and talking to them, give them the idea, I want to study this, and this is a way. And if you're interested, we can collaborate. You can write the IRB. If approved, then they can access the charts, or they can just, the way we did it, we just approach the IT team, where we send them the requirement. We want to look at this from the chart, and they can run a query and get the information back to you. So it's going to be collaboration.
Okay, thank you. Thank you, Doctor.
You're welcome. Excellent question. Any other questions? Go ahead, Nada, Ashraf. Your voice kind of far away, Nada. Can you check your mic? Sorry, Nada, we cannot hear you. Or at least I cannot hear you. So Arshad, go ahead, and then Nada, if you can check your mic and then come back after Arshad. Arshad, go ahead.
If I collaborate with some physician and I have access to his charts, and then he wants to collaborate with me, we collaborated. So what is the way forward?
Sorry, again, your voice in and out. Can you repeat the question again or write it?
Yeah, so if I collaborate with physician and have access to his charts, and at the same time, the private physician does not allow me to collaborate with other people. And so what is the way forward then?
So at the same time, the physician or the resident, what? I didn't get the last part.
At the same time, this physician does not allow me to share this data with other people. He wants me and himself to be on the project.
So this is the idea is you find someone who is in the system who is interested in collaborating. So if there is someone who is able to collaborate, and in my case, I will go to the top. So if you are talking to the resident, you can go to the chief resident or senior resident or the program director. You can, or faculty or attending physicians to tell them, hey, I have this idea, I want to do this research, and it might be helpful to collaborate with some of the residents. So you will find someone there who might be interested in some topic or some area, and then you can work together.
Thank you so much.
You're welcome. Nada, go ahead if you say. Yeah.
Okay, could you hear me?
Yeah, now we can.
Okay. So I just wanted to ask a question regarding, for example, I'm in Canada, I'm not in the US.
Yes.
Should I kind of try to connect with the residents in a certain hospital in the US remotely and then try to get, as you said, access through doing kind of a collaborate between us? Or how do I approach it? Because I'm a bit confused about this part.
So my suggestion was, if you live in the US, just to make connection and make yourself known to the program. Let's say I'm here in Lansing and I know there is residency program and I'm interested in internal medicine, and the resident program they have internal medicine resident here. So I will come up with the idea. I will approach the program director or the chief or some of the resident and see if we can start a collaboration. For someone outside, in your case in Canada, then if you can access or the same approach to some of the physicians in your area to work with your idea, that might be the easier approach. I'm not saying you cannot do it remotely, because what my fellows did in the first project, they were all over here in the US, but we worked with the IT and the team here at Sparrow in Lansing, in Michigan. So everyone from other country, actually there was one in Sudan in that group. So they worked with some of the fellows here and they work with the hospital here. So in your case, if you have an idea about doing some research topic, maybe some of the group here might be interested. Let's say one fellow in New York City will be joining you and interested in the same topic. So that fellow in New York, there are a lot of programs there. He will or she will approach one of these programs in New York and say, hey, we have this idea. Me and my fellow in NEDA in Canada, we are working on doing some research project in this topic. We are asking if we can collaborate with your residents to carry on this project as we don't have access, but your residents might have access to the clinical part of the EMR. If they accept that, well and good. If not, then you're gonna go to another program and you do repeat the same. So let's say you are successful. So you will have, let's say, Ala Al-Sayed, she's in New York. Then you and Ala will start working in collaboration with some of the residents in that program in New York City. So the benefit will come to you both and will come to the resident who is working with you from the system, the health system there, if that makes sense. So that might be an approach to carry on your idea.
That's a great idea. I just wanted to ask, are there any other alternatives, for example, if that wasn't applicable for any reason?
So the other approach is to come in person if you have some time, period of time. Let's say you want to take I'm not sure if you're working or you can come to the US for a few weeks. You can come, let's say, here in Michigan, and you can approach, let's say, a hospital in Flint. There are a lot of Sudanese people there. So if they have the residency there, you can, before you come, you can approach them. Hey, I want to come and just shadow with you. So they say yes, you come and shadow within first 2 days or something. You can see which one is able to collaborate with you or open for collaboration or helpful. So you just put the idea, share the idea with them and say, I want to do this. Is it achievable? Is it possible to carry on with your, let's say, residents? If they say yes, then they can approach some of the residents who are interested in the same topic or same area. And then you can say, hey, this is my approach. We're going to do this. What do you think? If they agree, then they can carry the part where they have access, and you can carry the other parts where you can work on writing IRP approval or writing the steps or whatever the project will need to be done to be completed.
Okay.
Thank you. No, that was the question. Any other questions? So I'm trying to make some collaboration with some of the residents here in family medicine. So I'm gonna try to approach the program director. We have a network of programs scattered here in the Michigan area related, and they have relationship with MSU. So if I'm successful in establishing some way of collaboration, if the residents in these programs are willing to collaborate, and you guys, if you are ready to collaborate, then that might be a good mix where you will have some ideas, or maybe they have some ideas. You'll get together, see who will do what, again, to divide the task, and then you can carry on different projects together. So I'm still in the process. I don't have many connection. I spoke to the chair of the department in the past, and I'm gonna try to approach her again. She's a new one, so she has many things to do. So I assume it will take some time And we have internal medicine residency here in Lansing as well. It's through Sparrow Hospital, so I'm gonna try to approach them as well and see if they are interested in collaboration and see if we can do some sort of collaboration between these programs. I think we can create different projects, and it's gonna be helpful for you, helpful for the residents who are in these programs. I know in the last year, there are at least one group of fellows here. They collaborated with some institution in the area of cardiology. So at least there was an attending physician in that hospital, maybe some residents who were interested in the same topic as the group here. So, yeah, so here, this one here was done by some of our group, and then this physician from the other institution. So I'm not sure which Lena or Sama, one of the fellows approached this, and then they said we are interested in this myocarditis thing. So he has the idea, they have the time, they work together, he has access, whatever. So it can be done. So this is for the clinical part where you really need to work on the actual charts or the hospital records and so forth. But you can do most of the projects done in the past couple of years related to literature review, the same way we were talking about telehouse palliative care. So you look at what's in the literature. So for that, you don't have to go to the hospitals. You just come up with the idea and look at the literature and see how many studies done, and then get a summary of these studies. And it's going to be a literature review about the topic. And the more specific for that topic, the more you can get published or get into a certain area where you can present your work. Sometimes we work it backwards. So by that I mean, let's say I'm interested in geriatrics. So I will look at which associations, what societies in geriatric medicine they are active. So I know two of them. One of them is American Geriatric Society. One of them is subacute or long-term. In the past, they call it AMDA. So we have two identities or two groups. They do annual meetings, conferences, where they accept the abstracts. So what I do, I will go to the first group, look at last year meeting, what kind of abstract they accepted. So at least I have an idea about the topics they presented and they accepted. I can come up with similar topics or related topics. I can go back to the meetings before COVID and see what's different in the topics. And I can repeat some of these topics. My repetition will be not literally repeating the same thing, but I'm repeating and comparing between before COVID and after COVID. So anything done before 2019 and anything done similar way or same after that. And if I can collect the information, I can present it to the same group, let's say the American Geriatric Society, and with the idea that I'm comparing data from before the COVID and after the COVID. Or I can do it with the other group, the AMDA group. I can look at what they did in the past few years, what kind of abstract they accepted. And I'm interested, if I'm interested in one area, I will look at how they did it. I can repeat that, but I can repeat that instead of the time period. I'm gonna repeat it in geographical area. Let's say one of the abstract, they were talking about telehealth in all the adults in Michigan. So they limited themselves in one area. So if there are a lot of fellows here in New York area or in Florida area, then we can get the same concept and apply the same method, but in the area where these fellows are interested. So we will do the same, but now we can say we are publishing the data about this topic in another state and see if we come up with the same results, get same conclusion, or maybe we can come up with different answer, if that makes sense.
Hello, Dr. Nader.
Hello, Dr. Amal, go ahead.
Thank you so much for the information. I have a question regarding the use of ChatGPT in writing an abstract or a manuscript. So I want to know about the drawbacks of using ChatGPT in the writing process. I remember that you told us about this in one of the meetings, but I was not able to focus at that time. So it would be great if you tell me again. Thank you so much.
You're welcome. So ChatGPT is kind of a new tool, and it's very helpful, but we have to use it with some cautious. So what basically it does, it will look at all the information on the internet and come up with some results for you guys. So if you give the ChatGPT, it's like Google research, Google search engine. So you put a question, it will give you links to websites where you can click and then go to the website. But instead of going to the websites, it summarizes these websites for you in the answer that it will give you. And you can repeat the question and it may go to different websites and give you different answer to the same question. And if it doesn't have information, it may make up information. So it can create information out of blue. Sometimes they call it hallucination. So it can generate some arbitrary answers for you for your question. So the information you get, some of it might be valid and you can trace it back and you can verify it. And some of it you cannot, and it's just because it's generated through the machine. And it's like you're talking to a person. If they tell you something, you can either accept that, the way I'm talking to you guys now, you can accept what I'm telling you as 100% correct, or if I'm on drugs and I'm telling you the same thing, you look at me and say, maybe he's on drugs. I'm gonna verify this information. What you do, you go and search it up, you go to Google, you go to other sites and find out, hey, his information is right, or maybe no, he is just on drugs, or he's hallucinating. So this is the same way with ChatGPT. When you put a question or query or prompt, it can give you some information. This information, you need to verify it. See which is valid, which is not valid, which is incorrect. And this is one of the limitations of ChatGPT. So if you want to use it in the literature, it can create an abstract for you, it can create a manuscript for you. It's easy done. But the problem is it's not 100% accurate all the time. So this is why most of the conferences or most of the art the journals, now they want you to, number one, if you used it, you tell them I was using the ChatGPT in my process, or this is written by or assisted by ChatGPT, so that they can look at the information and verify it in addition to if you did the verification, so that they don't publish something that's incorrect. This is the first part. The second part is what I'm using it nowadays is I'm using it in different aspects of my research, let's say. If I want to write something, I'm gonna do the literature review, I'm gonna look up things, I'm gonna make sure there is a gap. Then I want to write about this gap. So what I do, I'm gonna ask ChatGPT to write me the background about this. So it's either for it to collect some of the data in the literature, make a good background. For me, I will ask it to get some references for this background. So it will get some relevant references. So for me, it's going to be easier to just look at these references, verify what's written, and can modify the background that I'm talking about. So I will be working as a human, but I'm using it as a tool. It's like the car. I want to go to work. I can ask a driver, a taxi, to come here, pick me up, or I can drive my car or my bike, or I can go to the stops and bus stop and then take a bus to where I want to go. It's all these are tools. So it depends on how you use the tool. So for me, I want to just collect some information just to put a draft and then build on that, making sure whatever given to me is accurate. Then I want to look at more references, let's say, so I can ask it to get me more references. Then let's say I finished writing all the things from A to Z. In one of the cases, let's say I'm writing an abstract about the same, what we just talked about, the telehealth palliative care in nursing homes in 2022 to 2023. So I already finished my abstract. For me, English is not the first language. So I might misspell things, I might make mistakes, sentence might not be as clear. So what I do, I copy my abstract, give it to the ChatGPT and ask it to correct any mistakes or make suggestions as far as how can I rewrite or modify my abstract. So it's kind of another eye. It's the same way we do, like when you write something, you ask your friend, can you look it up? Or if you want to write your personal statement, you ask someone to look it up so that you can go over it and make any correction, spelling mistakes or English sentences might be just you flip it around and makes it more clear. So it's and again, I can use it as a tool to improve my abstract. So if I use it this way, it's going to help my way of completing my project. And then I'm going to send it, let's say, to AMDA. Then if they accept it, I'm going to tell them that I used it for this part of my, used it for the background, or I use it for the correction. And that's the way we should use it. In other places, they can use it for teaching. In other places, they can use it differently. But I don't think we should rely on it completely 100% as a valid tool or as a person that can write a manuscript or write an abstract from A to Z. As a tool helping you creating, drafting, finishing, editing, yes, but not rely on it 100% because, as I said, it's limited and it can create incorrect information. Actually, one of the articles just published 1 or 2 weeks ago in one of the big journals, Annals of Family Medicine. So the editor of that journal, he asked ChatGPT to write a brief, like let's say, abstract about how it cannot be as an author or how it cannot be used in writing literature or writing medical literature or as author. And it did. And guess what? He published it in the journal. So I found that article and I wrote back that it's a good way of presenting the tool, But in the community research community, I think we can still use it, but we have to use it as a tool with the certain things that I just mentioned. And I got that published as well. So it's kind of a letter to the editor. It's a small part, but it was published. So for you guys, if you want to use it, I have no objection. You can use it, go ahead. It's very helpful, very useful tool, but know the limitations. In another video, I saw some other researcher. He asked the same tool to write something about the area where he has some expertise. So the ChatGPT wrote the answer or the abstract and gave some references. So one of them is valid, but the rest, two other references, he made them up. So when the researcher asked ChatGPT, why did you get these references? The answer was, it seems these references are not verified or not published or something like that. So the ChatGPT can create some weird answers. So you have to be very careful in using it and verifying the information, the references and so forth, if that makes sense. Thank you.
Thank you so much, Dr. Nader. That makes perfect sense. I want to add that also ChatGPT helps in like giving ideas for applications for those who are interested in making any application. Just ask ChatGPT, for example, I want to make an application that targets vaccination in children. It gives great ideas of how to make that. So it's a good starting point. Thank you so much, Dr. Nader.
Thank you so much for reading this. I'm going to just here.
Have one more addition.
Go ahead, Sarah.
I tried using ChatGPT in the previous months, and to be honest, it's really interesting. There's only one small trick in dealing with it. The more direct in specifying what you really need makes it easier, and dividing the work into portions instead of giving it order to write a full abstract, it's always not accurate. But dividing, if you want to get something fixed even grammatically, when it's divided into portions, it gives more accurate answers.
Excellent. Yeah, I agree with you. So it's called the prompt. So you give it some prompting, and the same way we were talking about creating a research question. You start with big, and then you go down small. The same, you can ask ChatGPT, give me 5 points of whatever, let's say, background about the topic we just talked about, telehealth and palliative care. So it will create 5 points for you, and then you can ask that with another prompt, give me more details about each of these topics. So you're gonna go into some more details, and then you can ask it to get some references for each one of these details. And the more specific you ask, the more better answers, as you mentioned, Sarah. One other useful area, I use it with giving my other fellows a review. When they give me the manuscript, for example, I try to review it and make corrections and see what's the best option. So ChatGPT can help me. So I copy part of the introduction, give it to ChatGPT and see if there is any other correction that can be made. So it's kind of additional tool to use. Thank you so much, Sarah. Go ahead, Maud.
Hi, I just want to add something to what Dr. Amal was saying. So the only downside of the ChatGPT is, let's say if maybe 5 or 10 of us give the ChatGPT the same task, the probability of giving us the same result will be high. So if you provide the same result to the same application or to the same research proposal, it will eventually be picked up by people that you are giving the same result from the same application. So you can use ChatGPT as a partial or maybe compartmentalized portion of application, so that you can add something out of your hand or out of your head into whatever you are writing. Then you can add something from ChatGPT. But if you just completely write whatever you are intending to write from ChatGPT, it's obvious whoever is reviewing, picking or reading your personal statement, research, abstract, it will be obvious that you didn't write that. So it's better if you use ChatGPT as a compartment-wise way of application rather than straightforward 100% resources.
Completely agree. Thank you so much for adding this. And thank you, Aman. Go ahead, Aman.
I came to know recently that there are many types of like artificial intelligence. Like there's ChatGPT and there's ChatGPT-4. So I hear that ChatGPT-4 is more specific and it's not for free, but it's worth the subscription. So I don't know if it gives more accurate results. I'm not sure about that.
So ChatGPT, it's kind of iteration. So this is generation for the fourth edition or something. So it's same, but it's, as you said, it's more advanced. So maybe the answer will be more accurate or maybe more concise.
I have another question. So do we have always to declare that
Go ahead.
we use ChatGPT in writing an abstract, for example?
So if you follow the publisher instructions, they're gonna be updated, and most of them, they will have a question about if you used it, clarify that. So you have to mention that I used it, or you decline it, you say I didn't use it. So in the future, at least, but for now, most of the journals will ask you.
Okay, thank you so much, Dr. Nader.
Excellent question. Thank you.
Any other questions?
Go ahead, Maysam. Go ahead.
No, I don't have a question. I'm just asking if anyone else has any other questions.
Again, thank you so much, everyone, for joining this meeting. And thank you, Dr. Maysam, for moderating this meeting. And thank you, all the presenters, all the contributors for this meeting. I wish you all the best. Have a nice day or night. See you next week. And hopefully you'll have a good time and happy Eid in advance. Assalamu alaikum.
Thank you, Dr. Nader, and thank you for everyone.
Thank you.
Thank you, Mr. Robert.
Thank you, Dr. Nader, and Eid Mubarak for everybody.
Thank you, Dr. Nader, and Eid Mubarak.
Thank you, Dr. Nader.
Thank you, everyone. Have a good one.